All right. Welcome, everybody. Hello and good afternoon. My name is Garrett Schmidt. I am the managing editor for ACOExhibitHall.com, and I would like to welcome you all to the second of a three-part webinar series entitled, What Do I Need to Know to Relaunch Medicare ACO? Today's session is part 2 and covers actionable data at the point of care and analytics. A few items of note before we get started, just as before. First of all attendees have joined today in listen-only mode, so you don't need to worry about muting your mic. That's done for you. Secondly, I would like to inform you all that this webinar is being recorded, and so you'll have the opportunity to rewatch the session and share it with colleagues after the conclusion. And also a link to this recording will be emailed to all registrants following the presentation, even those who are unable to attend today. Finally, during the webinar, you'll be able to submit questions to our presenter, so feel free to do so, and we will answer as many of those as possible during the Q&A session at the end. And these questions are also being recorded, so even if we are unable to get to yours during the allotted time today, we will follow up to answer it via email afterwards. So without further ado, we'll move forward here. Our presenter today is Chris Gates, who is the Chief Executive Officer for Health Endeavors. And we'll turn it over now. So welcome, Chris.
Thank you, Garrett. Good morning, everyone. We'll go ahead and jump right in. We're going to do a little bit of a recap from last week, just so you know about why the risk score matters, because it plays into our actionable data at the point of care. So last week we talked about why the risk score matters, and the biggest reason it matters is the risk score is what calculates your financial benchmark. It calculates the financial benchmark for the patient, provider, facility, and organization. So we want to make sure that those risk scores are correct, because they start driving that actionable data that we then bring to you at the point of care. So again, keep in mind, every patient has a risk score and a financial benchmark. Every provider, facility, and organization has a risk score and a financial benchmark calculated using their risk score. The lower the score, the better health of the patient. Healthiest to the sickest. That's why they call it risk stratification or ranking. The risk score is based on the patient's demographics and diagnoses. So last week we talked about a few strategies in making sure that score is correct at the point of care. So we're just going to focus on that for the recap of this section this morning. So here's our example of how a diagnosis impacts the scoring. So if this was the incorrect diagnosis, what was coded on the left, 0.162, and this was the correct 0.511, you'll see the difference in the risk score. That will also associate to a difference in the financial benchmark. Again, we're bringing this up because we want all of your actionable data at the point of care, as we move our way into that this morning, to be as accurate as possible. And this is one of the most important features of a value-based program, your risk score and your associated benchmark. So we went through these last time, we're just going to touch on them quickly. So the impact of a decreased score, you can see here, that let's say this here was the accurate score, 1.973, which results in a 17,800 benchmark for that patient. But two diagnoses, HCC diagnoses, were not coded, so the benchmark drops from 17,000 to 10,000. And then on our next example, you'll see they actually they went in and coded the correct diagnoses, and it went from a benchmark of 9,611 to 16,833. So just a couple examples that we went through last week, showing you just how big an impact those diagnoses have on your financial benchmark. Diagnoses go into HCC risk categories. HCC risk categories have a value. They're added up, add the demographic. That's your risk score. And then it gets multiplied out based on a number of different factors into the financial benchmark. So that is the basis of your value-based program and how your risk score and financial benchmark works. So our first point will be, how do we get EHR point of care coding strategy very easily using our claims data, either your ACO CCLF, your Medicare Blue Button, your commercial data, whatever it is. But what can we bring to the EHR to assist in coding? And also keep in mind, after 12 months, I think my slide deck is jumping a little bit here. After 12 months, your diagnosis will fall off. Okay, so if it's marked here as it's off, coded as out, of being removed, you have to code that again, or what happens? The risk score drops here, and if that diagnosis should have been coded, right? So if it leaves uncoded, then your risk score is going to drop, and benchmark drops as well. So we want to make sure that all these crossed out at the point of care. So you want this delivered into your point of care so that when the patient comes in for their visit, you call up the patient. You immediately know, we'll come back to these other items, patients above their benchmark. But I also am looking at their score, and I'm going down here to see, well, what diagnoses have been crossed out, because I need to recode those or the score will drop. So this is your first point of care action to complete, is recoding those diagnoses that are going to fall off in 12 months. It will take 12 months for changes to take effect. So keep in mind that while I'm doing this, it's going to take 12 months to get the change. That's why Medicare doesn't give the benchmark final reconciliation until September of the year after the performance year, because they need all that time for all those diagnoses to come through from the prior year and calculate them. So that's why some of you see big adjustments. If you start in January and you've done a lot of work all year long, you'll see some adjustments possibly in that first year, more likely more in the year after. But keep in mind that it does take 12 months. So the other thing we talked about, and there was great questions about this. So again, this is our first action item for at the point of care. This is a picture of an EHR calling up the patient, and let's make sure we're coding those crossed out diagnoses. The other thing is, those are all the diagnoses of the patient from everywhere they've been, because it's using claims data, not just what's in the EHR. So it's everywhere that view is. What you want to make sure is that your diagnoses are there also, not just what's been removed, but did my diagnoses make it into the repository? So here's an example of the 4 codes being sent to Medicare, but 2 codes, because the billing company or the EHR, we don't need those to get paid, we only sent 2 codes. So a lot of our ACOs have experienced this, which results in, if you don't have 2 codes going, results in a lower risk score for a patient, a lower benchmark for the patient, which extrapolates to a lower benchmark for the ACO. And then we had some coding questions, which we did follow up with Medicare. Yes, you are limited to 4 codes per service line, but you can include up to 12 diagnosis codes on a single claim line. Only 4 of those codes can be mapped to a specific CPT. So you really need to work with the same in all your programs, not just Medicare, your Blue Cross, commercial, Medicare Advantage. If you're in any value-based program, make sure they're taking up to 10 to 12 codes. If they say we can only take 4 to 6, then make sure you're always sending the HCC codes. And those would be the codes that we showed you at the point of care. These are all HCC codes that impact the score. And you're doing that at the point of care. So at the point of care, you're making sure all my diagnoses are there, they're going through the data, and I'm recoding any removed. So that's your first actionable data, which will help you the most in the value-based program, because a right risk score can get you to the right benchmark and can get you to shared savings as one strategy. And then we talked a little bit about why is the annual wellness visit so important to get them in. Yes, we want to get them in to manage them, but the biggest reason to get them in is to do that HCC coding at the point of care. I shouldn't say the biggest reason, but the biggest reason related to getting your risk score and your financial benchmark is doing the HCC coding at the point of care. You're getting all the diagnoses presenting to you, make sure yours are there, and make sure you're recoding ones that have been marked removed. And then we went through last week, quick wins on the risk score. Schedule the annual wellness visit. Do your HCC coding at the point of care. Make sure all your codes are there. Make sure all removed are coded again so that they count. Capture the HCC diagnosis code, all of them, with all your payers that you're in value-based programs with. And then you need to analyze your claims data. So these are more in here for reference, but I will go into the tool just for those that missed it last week. So once you start working your way through my risk scores are correct, then you can start doing some going across the board of every provider and looking at, based on their score, let's say the 1.48, it's gone down 17%. That would lead me to believe diagnoses are being removed because you can't change the patient's demographics. Only Medicare can change that by age, gender, enrollment type. You've got a benchmark of 13,559 for this provider, but you spent 15,192, which means you're at 112% of your benchmark. So once we get that HCC coding point of care, and it's correct, we can start really looking across here to start seeing other types of trends. So that moves us, so our problems last week that we talked about is getting the risk score right, accuracy, how to, strategies to get it right. The best one is the HCC coding at the point of care. Is my diagnosis there? Recode the removed diagnoses. And then our next problem later in that webinar was, okay, we have the score right. Let's start looking at our trending, but we have to manage the patient then. We have to make sure that, okay, we know their risk score is correct, so we only have so much money. We only have, based on that risk score, let's say $10,000 to spend on that patient. So we've got to keep them out of the ED, readmits, CT scans, those duplicative services. So we have to manage their care to keep them within the spend Medicare has allocated for that person. Our next problem we're going to talk about is there's lots of data out there for ACOs, clinically integrated networks, employers, and payers. There is a lot of data out there. Some of it structured, some of it unstructured, but very little of that is being put in front of the provider team, like the HCC coding view we showed you, and very little in front of the consumer, which is, we see, resulting in a lack of engagement and empowerment. If you're a provider and you're like, well, these patients are coming in and I don't know where they stand in our ACO, you start to lose engagement because you're like, I really don't have any control over changing how this is going to impact the patient. You lose engagement when you don't feel a sense of control. Same with consumers. We've showed this slide multiple times. Again, this is our concept of let's get the data out of the committee meetings with stacks of Excel papers or trending charts, and let's get it to the provider team so they can have it right there in their EHR or in another accessible manner if the EHR doesn't have an API that we'll talk about later. So as we move forward, our goals now to address the problem of all the data out there is to get data that's actionable, to build provider team awareness, get them to buy into your initiatives, and get the consumer aligned to you, and get them empowered with their data in their care. Because there's also actionable data that can go to consumers to push them to come in and bring that data to the provider. So we hear a lot, providers, we just said earlier, I'm in an ACO. A lot of them don't even know they're in an ACO. For those that do, again, they don't feel empowered or engaged. They have a sense of a lack of control because they're not being told, how is the data being used to benefit me in the point of care. So we've done lots of analytics and we've delivered it, lots of reports, and I guess what really got our thinking caps to start doing better is doctors saying, you hand me an Excel, it's going to go into the garbage. I can't work an Excel into my workflow. I can work something that you put into my EHR or that's simple to use, a patient search, for example. I can utilize that if it's in my workflow and you make it easy to read. So we took that feedback and we said, what's the next step then? To make it actionable, bring it to the point of care, and we're going to use some data-driven intelligence to do that. The first piece that we, before we get into the clinic provider EHR, let's talk a little bit about surgery, someone heading into surgery, or someone at the ED. How many of you today have a patient searchable database everywhere that patient's been into their claims data to pull that down in the ED or when they're going into surgery in that pre-cert phase? We find very few are using their data that they're getting, their claims data, which you're getting everywhere that patient's been. Blue Button's 4 years, weekly updates, Medicare's monthly, and you get 3 years back now when you start. but let's get that data to the ED. So if I come into the ED or I'm going to have surgery, we can put it in the EHR, which we'll talk about that. But if I'm headed into the ED, shouldn't I just be able to do a search of that patient, whether I'm in my EHR or otherwise, and bring up that patient's history? Very simple. Brought to the emergency room just by looking up that patient, verifying their date of birth, gender, etc. I've got their history here, their Medicare claims history here, everywhere they've been. And if you tap into this, when you're coming to the ED or they're coming in for surgery, you instantaneously have all of their encounters and utilization brought to you at the point of care. So that's one strategy we see that we really think that more needs to be done in the going into surgery and having an emergency visit where those teams can access it either through the EHR or through that patient searchable database, bringing that data to them. And we'll walk more through the data components as we move forward. But I think after your HCC coding at the point of care, make sure your diagnoses are there, make sure your recode they're removed to get the right benchmark. The next one would be, how do we get this patient search into our ED teams, to our surgery pre-certification teams for the Medicare patients, Medicare Advantage, whoever is your value-based population that you are in a risk or value-based program with. So next we've covered two, the HCC coding at the point of care, getting your ED team set up with access to the data, so anybody comes to the ED gets it instantaneously rather than it sitting in an Excel spreadsheet not available to the ED. Same with those pre-surgery certifications, and there's many other use cases. Someone's heading into a nursing home. Get them set up with searchable access to pull it into their repository, regardless of whether they're in your ACO or not. So start making that searchable database available to the points of care where the patient may come in to have encounters, so that they always have that history moving forward. The next place is in the logical places in their primary care or specialists in their EHR. Or again, if they can't get it in the EHR at the point of care, to do that simple patient search I showed you. So what is an EHR API connector? What it does is allow seamless integration between your EHR and that actionable data, feeding it into the EHR. Actionable data such as cost, quality metrics, utilization, care gaps, and it's all the patient encounters. So API is Application Program Interface. It allows instant access, no login required outside of the EHR. Now you can also do the patient search that I showed you as well if your EHR can't get it into their system. But most of the work to get to an API is done on a vendor, just so you know, because they put forth, here's our API process, vendor, you go and do it, and then test it. So it's really just a seamless integration that you want to log in the EHR when the patient's there in the clinic or in the ED, right? And I'm going to call up that patient's record in the EHR, and it's going to also render their claims, can be also combined with clinical data, at least a 3 to 4 year consolidated history for you to utilize for your ED purposes, your surgery pre-certs, or in the clinic, you've got a variety of different things you want to do. You want to look at the risk score, the financial benchmark, and we're going to walk through each one of these, cost and utilization, and quality and disease and wellness care gaps. We'll also talk a little bit about how we enroll consumers in text alerts that will tell them you have things to complete, you have care gaps. After they leave that encounter and months go by, we'll start mining the data to say, oh, you need to go back in when you can, because here's the list of care gaps or quality measures that are now due 6 months later. And we'll talk about an interactive health history form as well and care coordination. But let's just walk through, hopefully there's not too much on here, just to give you the first level of how does an API work. So as I said, the provider team opens the patient record in the EHR. So this is in the EHR here. They're opening the patient's record. It then goes out to our EHR API connector and says, does Health Endeavors repository have data for this patient? Claims, clinical, Medicare, Medicare Advantage, Blue Button. What do you have for me? And it then renders, if a match is made, will render back to the EHR that patient history form. So it might be easier just to view it. So it's going to render this back to the EHR, and they'll have all the tabs, and we're going to go through the different sections here fairly quickly. And then it renders it. At that same time, we can pull data out, such as a CDA or a FHIR resource, to start helping you with quality metrics. Or you can enroll the consumer in text alert so that you don't have to have a call center program for your populations. It's going to text alert them when a quality measure is due for them to come back in. So that's really how it's pulling data in after a match is made. Once a match is made, we can pull data in for other purposes such as text alerts. So let's walk through the components of our patient history form that would render in the EHR. Your risk score is going to render benchmarks and spend. So if a patient is over, and this is feedback from providers, and we'd love to get more feedback from providers, they wanted to know right at the top. You say I'm in this ACO, okay. Now you're telling me this patient has come into my office, they're above their spend, they're greater, I know, right there. This patient is going to, either is predicted or is going to be over their benchmark. And if they go down, if they want to, they can see by how much. But more importantly, this patient is over, so let's take a little bit more time with this person during this visit to go through their cost and utilization, their quality metrics, follow the red X's. You can see this patient isn't doing their management, they've had some admits, etc. But the first step, what we were asked is, just tell me where they are with their benchmark. So I know immediately you're just telling me they are above what their benchmark for that individual patient, they're above. So that's the first step we did. And then we talked about this piece. The second step was providers were like, well, my patient's going lots of different places. So give me a quick synopsis of all the diagnoses everywhere the patient's been compared to last year. Tell me what's been removed and what's been added so that I can recode those ones that are removed if they're still applicable, because the diagnosis will fall off after 12 months. And then I can make sure all my diagnoses are there. If they're not, I'll make sure I code them today. So first step, tell me above or below the benchmark for that individual person. Next, let me do my HCC coding at the point of care. Next, move into cost and utilization. And it's not always the doctor doing this. It could be the nurse. It could be a care manager you have placed in your office. When I say provider, I always try to add to the end of that provider team. So it could be different who's doing each one of these steps. So next you move into cost and utilization. So you've also got your medications over there, what's been added and removed. So you'll know all medications, not just the ones that you've prescribed. This is everything that's been filled under that claims, under that payer. So then you can move down to cost and utilization. Again, red matches the red up here. We're above the benchmark, or we're predicted to go above. My last wellness visit was in 2017. I've had an admit that you may or may not know about as a primary care. I've had an MRI visit, so let's start going through these items that are marked in red. And again, we're taking feedback all the time from providers. What more can we put on here for you to assist you in having a conversation with the patient? We found admits was good. The radiology, the readmissions, because in most cases the primary care didn't know that they had had a hospitalization. Perhaps they'd gone in from a specialist referral, had surgery, and were treated by a hospitalist, and so they weren't made aware of the hospitalization. So cost and utilization next at the point of care. Then your quality metrics. So quick, easy, that was another big request from our providers. Quick, easy, they're there in front of me. What can I get done? What do I have an opportunity to get done? MedRec, and some of these are different now for 2019, and they're different for HEDIS programs, so it would depend on what population that patient is matched to. Fall screening, they don't have a pneumococcal, no BMI, so quickly they can go through the quality measures when the patient's there and know what's not done for this patient, what doesn't apply because they're out of age range or they have a gender exclusion. So that was the next big request from providers, is quality. After that was wellness and disease. So using quality metrics and other evidence-based medicine outside of the quality measures, what other care gaps can you apprise me of? The no blood pressure for this patient, no tobacco screening in the last 12 months is what's coming up. The yes are diagnosed with hypertension, and this is what the gaps have populated. The biggest thing is they haven't had a wellness visit since 2017. The next request we got was out of network. So I've done HCC coding. I know when they're above their benchmark. I know all their quality, care gaps, cost and utilization. But I see people going out of network, and I can't control that cost. But I am responsible for it. In any value-based program, you're still responsible. So we started color coding, so if they flip over, they want to go down further into the data, we start color coding every encounter for the patient. So, all these are Part B out of network, the red are Part A not out of network, and then they can drill into those encounter and see who they saw, what was the diagnosis, all those different things. Or they can go to the bottom and get a full history for someone that's doing care management and really wants to drill down into the data. So that was the next piece, was incorporate out of network. You need to communicate to your people, who is in network, and this seems to us to be the easiest way to do it. If you start seeing trends of them going to an out-of-network provider, either add them to your network or start teaching your networks that they're out of network. They may not be managing the care, and we're still responsible for it. So it's really care. That's, again, you've lost that sense of control if they're going out of network. They're not following our protocols. They're not doing our quality metrics, and that's not good in a value-based program. The next big push we heard was we can't reach all the patients through phone calls. There's not enough staff to reach people. So how do we start auto-generating care coordination events for people? Push general or focused content for a patient to them based on their age, their gender, their diagnosis, their medication procedures. So let's push that to them, to the consumer, to get more education to them, to get a more automated care plan to them, because there's no way that we can reach all of these people. So again, on both sides, the admin can go here and view all events completed by a consumer, and the consumer on the other side will generate the events. So if I go to this patient's things to complete, you'll see here are the events that populated for that person, and they can be generic, or if you have a content-based system to integrate in with this, such as Mayo Clinic data, their care plans and all of that, or HealthWise, you can do it either way. You can create your own content, quick and easy, questionnaires, videos, handouts, or you can feed other content. And the consumer can also send information in addition to answering these back to you. You would then access that in the EHR, going to, I want to look at, view all that patient's events. But they're being auto-generated for you by sending out questionnaires, care plans to the patient to then populate back to you their responses. So that was our next big question, is how do we reach more patients? Because if we only pick the top tier, the sickest of the sickest, and that's all we can work, that's all the staff we have for, we aren't managing the patients that are getting older, having more conditions assigned to them. We don't have an automated process for them to get content from us, to get care plans, text alerts about what you should be doing. So this is a way to reach, in a more automated way, all of your people, and ultimately always be pushing them back to the primary care provider that's in the value-based program. The other component is virtual care. I just want to highlight this because Medicare did approve the virtual care codes for virtual check-ins. That's a video, you can see them. I think it's $14 for every 5 to 10 minutes. And then the other one for a patient would be uploading images and video that they can send to you, bringing that to the point of care. Virtual check-in on the point of care. You either need to come in or you don't need to come in. But I'm still pushing, the patient's still pushing their information to you, and now Medicare has agreed. While it's not really high reimbursement, it's finally reimbursement for those things to add into your cycle of a quick touch base with someone. And a lot of virtual check-ins with the video can qualify to satisfy a quality measure without bringing them into the office, which in turn brings down your costs in your program. Enrolling consumers in text alerts or email alerts is very easy. When you're on that page, you just simply put in cell phone and email. The great thing now is Medicare has included all of their address information. So if you wanted to make them apprised of, get your data, sync it over to us. It's a very easy process, and get your text alert started. It's a very easy process now because you have all their addresses. You could notify them all. So the next stage, and we want to hear feedback from everyone, is let's start moving into more predictive now. We're seeing what needs to be done, and that's great, and we can start closing those gaps. We can start seeing who's now are predicted to go above their benchmark. We can do HCC coding at the point of care, but let's start getting into more predictive. So that will be our next evolution, is to say, using our current algorithms for the text alerts, we can add in things such as not taking your medication, not filling it. You've been prescribed a medication. You stop filling a maintenance medication. You've been to the ED, or you've been to, you haven't been to the doctor. But there's all types of different data we can add in to send an adverse event notification. We're predicting this patient is going to end up in the hospital using the data. So that's the next evolution, to stay ahead of what's going on with the patient today. What we can mine to say what's not done, let's now start using those algorithms and combining them to start predicting. We talked a little bit about consumer empowerment. We think it's very important to bring them into the mix. So just like the provider saying, oh yeah, I'm in an ACO, and now I have a sense of control. You're feeding this data to my EHR in my workflow, and I now have a sense of some control that I'm contributing, that I can contribute to this ACO, and our team can contribute to the cost savings because you've brought it right to us, easy to read. How can we push this consumer to also bring actionable data to the provider? We can deliver their score to them, and we can start teaching them, how does your score get improved? I think the biggest way that we can teach a person to improve their score is same as what you're doing when you're looking at those diagnoses and medications. Engage them in their data. Are you even aware of this diagnosis? Are you not managing it, management not required, and put some notes about this? And then again, push this back to the provider, back in that EHR view. Go through your medications and say the same thing. While those medications may be listed on their EHR, we also want to know, we want the patient to interact with us and say, oh, I may be filling it, but I'm not really taking it, and here's why. So that when they come in, you have gone from your patient history page, I can get back there, you've gone from this page here that's telling you everything they're diagnosed and all their medications, and now you've gone to, well, patient, tell us a little bit about these. What are you really doing? And let's just do it in quick, easy to click buttons that feeds back to the EHR connector. And then we want them to do their things to complete. And again, these all can get pushed back, same thing, to the point of care. Text alerts to get these done, push them to their primary care to complete them, and the primary care sees that same view on their side. So again, just to recap, data goes into two buckets with us. We either put it as an incomplete care gap, which is usually an incomplete quality measure that's being reported, and a text alert goes to the consumer, and it gets fed in that EHR connector. Or we put it as complete, and we see that it's done. It's completely done, a BMI is done, and what else is done. Then we put it into the quality registry reporting for scoring. So we can say complete, we're going to put it into the registry. Incomplete's here, get a text alert. Again, the CCLF data has the addresses now for our patients to do a mailer to them if you wanted to. So we talked about this. I'm going to talk about the back end here. We talked about doing the patient match, rendering our claims and combined with some clinical data for the quality measures in here, pulling it out and enrolling the patient in text alerts. But also at the same time, let's see what we can work with your EHR to pull the quality data from the CDA, fire resource, if they're there, and use that data to seamlessly report your quality measures. So at the same time we're rendering and pushing data, we want to start sampling with pulling data, clinical data, and for the primary purpose of let's automatically start filling in your quality reporting repository. I've got reds here, that means non-performing, and lots of grays, that's not good. So if you just look at a high level of this, reds, grays, not good. But you could start seamlessly pulling that through the API, your clinical data, and whatever is the best way for the EHR, and doing it seamlessly, again, taking that burden off your providers, and then getting you a gap analysis and getting you your scoring that you can then ultimately push to your providers. And also, just want to keep reminding everybody every year, make sure before you submit your quality measures to do the optimal gaps analysis, which will tell you the best number of patients to submit. So from this sampling and scoring, we tell you in each measure which ones to submit. And then ultimately, you can start rendering that into quality and financial performance that you can, if you want, render back to the EHR in a dashboard. So this is an example of a scorecard, or they can pull it at the point of care. But again, let's start getting all of their populations. So same to the patient, that their individual patient, that they're being scored and identifying all the gaps. They can do it by provider and facility and ACO. As we go down here for their cost, spend, benchmarks, well, how are they doing on quality measure performance? How are they doing on cost and utilization? That one's a really, lots of red on that one. And then what else can we be doing? Like we talked about with the EDs and the going into surgery, how can they access this data? So today they can go through us to do a patient search and bring that data up. They can get it in our EHR connector, have it go into the EHR. And the other piece we're doing is, especially with Blue Button, is how do we set up an API so that if you want to build something different than our patient history, but you want the data that we've gathered through the patients or otherwise, let's set up a universal API. These are all the ones that will be forced to be sharing, are now or going to be forced in 2020, in addition to Medicare Blue Button, to start sharing that data. And we heard great news this morning. Some of the payers have already started distributing 2 years of claims history to their providers. So this would be a repository that any urgent care ED could access. You could set up your own interface using the API to pull the data. Insurance agents are also asking for it for Part D plans and hospital certifications, pre-certs. So in addition to all those points of care, there's all kinds of other uses for the data out there that people want to start utilizing. We do think people should start considering transitioning to the Medicare Blue Button data. Keep your ACO data, but the Blue Button data is 4 years, but the best thing about it is weekly updates. And the other good thing about it is you keep the data if you leave the ACO program. So if you started today, in 6 to 8 months, you could probably have all of your data through Blue Button instead, just by patients syncing and sharing it with you. So again, the biggest reasons are weekly updates, and you get to keep that data. If you leave the ACO program, they're going to stop the feeds to you, whereas the Blue Button data will keep coming. Again, if you want to click on the slide deck, slide 62, it will take you to the patient access rule. That's going to start saying that all these other payers need to start setting up APIs for people to pull the data. Analytics outside the point of care, I do think there is a place for those. We have lots of analytics outside the point of care, but again, when we started listening to doctors and we started looking at everything we had, we started saying, well, let's find out from them what they want, and let's bring it to them at the point of care. Probably one of the best ones for outside is aggregate expenditure and utilization, where you can instantly know in your service lines where they're above or below the benchmark. So if you wanted to look at it from a service line view. Just to start closing up, if you want to stop in and visit us, we have a conference room. You can meet with us at NACO's April 25th, and if you want, we'll send information out after the call. We're going to be in Kansas City May 2nd and 3rd about expanding and diversifying your ACO services into directly contracting with self-insured employers, so expanding your population from Medicare to commercial payers and to those TPAs and self-insured. We're expanding to get your health, get the right benchmark on a webinar on Thursday with Enjoin, who's going to talk more about audit and how to audit to fix some of those coding issues, in addition to our HCC coding at the point of care. Remember, this is for all payers, all programs. You just need to get the data fed into the system. We appreciate Garrett hosting this, and I will go ahead and get him unmuted here. Just hold on one second. Garrett, you should be unmuted.
All right, great. Thank you so much, Chris. That was a wonderful presentation. And for those of you who did submit questions, we were having a little technical difficulty on our end today, but we will definitely get back to you via email with the answers to those inquiries. Turn your attention, if you would, to the contact information on the page here. You can, if you would like to get in touch with Ms. Gates directly, her email and phone number is on here. I would also encourage you to go to the Health Endeavors booth on the ACOexhibithall.com website, and you can, at that place, learn more about them and connect with their team. Thank you all for attending today. I hope you found the presentation informative and helpful. And again, for those of you who are coming to NACO's pretty soon, stop by and see them at the booth, and I may run into you as well. So have a great rest of your day, and thanks for attending.
Thank you, everyone.